Okay, hi, this is Elliot Fishman and I'm live and today is October 29th and it's great to be alive. I guess I should say that and like to welcome everybody to our Facebook Live. Today is I have to finish up my RSNA talks. You know, with RSNA not being live, everything is being done pre-recorded, or some of my refresher courses on cinematic rendering was switched to PowerPoint, and you need to redo that. So you need to do them. And then, of course, your lectures, even if it's a perfect lecture, which is the only thing I would have, of course, it's hard to, you just can't post it and then have people look at it because it makes no sense, because typically you're talking obviously when you're doing a presentation. They're asking for simple PowerPoints without any words. And so you need to add a bunch of things. If not, people are just going to be doing this, saying that's a good case, and moving on. They won't learn anything. So that's a challenge, and it's due by 12 o'clock tomorrow. So I am finished. I stayed home today even, and I'll go in tomorrow, but I stayed home today, which is unusual, and I will get it done. Behind me is, it's raining out. To let some of you know, we had a terrific speaker last night, Sarah Moskoff, who's the founder and CEO of Winnie.com, or Winnie, which is a childcare company. It helps you find childcare. Spectacular talk. Sarah went to MIT, then went, when she graduated, was at Google, and then she was at YouTube, and then she was at Twitter, and then Postmates, and then she had the passion and the chutzpah to form her own company about 4 years ago, and it seems to be going very well. It's like any new startup, it has its challenges, of course, but it seems to be making great strides, and the company's impressive, but she's even more impressive. I think, just her vision. I know a number of the physicians, a number of radiologists who are on the call, and even non-radiologists, just told me how impressed they were by her and her demeanor, and just her, you had that feeling how confident she was in herself and her ability to be successful, which is something that indeed is really nice to see. So we thank her for that. And 2 nights ago at Hopkins, they had Ed Catmull speak. Ed was in obviously back home in California, in the Bay Area, and he spoke. He did a Q&A for about an hour, answering questions about his career, what he's done, his passion, his interests, his thoughts, and his experiences, and Steve Jobs, and all sorts of wonderful things. And as usual, Ed was just terrific. It's not online yet. I know they recorded it. I think it's supposed to be online. If it ever gets online, it's surely worth it to spend your time taking a look at it. So that part's really good. Now, one of the things I was mentioning, I'm preparing and finishing up my RSNA thing, but one of the things I did finish already, for the last couple of years, I've been part of a session which is called CTA versus MRA, and we typically address about 5 or 6 different applications, and then we have a presentation on CTA, a presentation on MRA, and then we discuss some of the thoughts about which works better when. It's a little bit trickier this year. What's happening is I recorded a 10-minute talk on CTA of the renal arteries, and Woodard is from Chicago, was speaking on MRA, and then we answered a few questions, but just the questions are in text form, which made me think about, I need to expand on my CTA of the renal artery talk. So in fact, I expanded from that 10 minutes to about 30 minutes, and we recorded 2 lectures, which will be on CTisus the end of November, beginning of December. But let me talk to you about CTA of the renal arteries. And CTA of the renal arteries is one of the really good applications where it's a combination of fast scanning, thin sections, and post-processing. You think about the renal artery, so what do we look for? Well, the first thing is renal artery anatomy. When would this be important? It's important in many situations, preoperative planning, but renal transplant is the classic application. Typically, you'd like to remove the left kidney for the donor, but you want to know which kidney is better in the sense of scarring, in the sense of size, in the sense of the renal arteries. Multiple renal arteries can make surgery more difficult, so you want to know how many renal arteries there are, where the renal arteries are. Is there prehilar branching? That all becomes very important. Now, obviously, we look at the renal artery in cases of tumor, but I didn't discuss that in the talk, in the sense we look at the renal artery and look at neovascularity in the kidney per se. That's a way of distinguishing clear cell from papillary cell renal cell carcinoma. But also, the greater the vascularity of the renal artery and the tumor, the more aggressive it is. And so tyrosine kinase inhibitors may be better. A lot of work's being done with genomics and radiomics looking at those features. So that becomes important in and of itself. So also, when you look at renal masses like angiomyolipomas, ones that have lots of AV shunting are more likely to bleed than ones that are just somewhat vascular with no significant AV shunting. So that becomes a very practical point and very practical application. But think renal donors as the poster child for anatomy. And the next thing I spoke about was renal artery stenosis. A number of causes for renal artery stenosis, from neurofibromatosis to fibromuscular dysplasia, but just classic atherosclerotic disease is what you think about. Typically in the proximal vessel, often with calcifications, but not necessarily. So we'll be looking for the degree of stenosis of the vessel. We'll be looking if there are multiple areas of involvement. We're looking for perfusion changes. So when I'm doing arterial of the renal artery, I may only be doing arterial phase. I typically do not do non-contrast. Now, if you said I was looking for renal artery stenosis, I would probably get 90-second scans as well through the kidneys just to look for perfusion changes. Sometimes you want to know how important the stenosis is. Besides quantifying it, it would be good to look at perfusion change. If you see perfusion change like slow perfusion, then you know it's more critical. So that's renal artery stenosis. Again, in that scenario, 3D imaging, both MIP and volume rendering, are particularly helpful. MIP is particularly good. Now, just looking at the axials, I get my hand in the picture here, there I am. Looking at the axials alone is not good because often the renal arteries come at angles 30 to 45 degrees. And so when you look at the axials, you kind of don't get things exactly right. So either you can do oblique, you can do a line along the vessel margin, but MIP and volume rendering work very nicely in that regard. Now the next thing is fibromuscular dysplasia. In some sense, FMD is in some ways thinking about the renal artery like renal artery stenosis. You're looking for changes in the renal artery. So what are we looking for? We're looking for beating. The most classic thing in FMD is beating of the renal artery. It's usually in the middle third of the renal artery. Stenosis is in the proximal third. Now, it's important to remember also with FMD, you also may see aneurysms. You also may see areas of stenosis. So FMD has a spectrum of appearances. It's also important to remember with FMD, we may be scanning the entire chest and abdomen because FMD involves multiple vessels. I've seen a lot of cases recently in the hepatic artery and other mesenteric vessels. Also in the carotids is not uncommon. So you're going to be doing a bigger volume of the patient. So timing is critical, but with fast scanning, it's not going to be an issue. But again, you're looking at the renal arteries, and now we're looking for beating. Okay, what else? Well, then we look for things that can be either due to trauma or can be congenital. We look for renal artery malformations, AVMs, or renal artery fistulae. Malformations are typically congenital. You see a big vessel often, but then you see early draining veins, so you know it's an AV malformation. It can have mass effect. And if you don't have the arterial phase imaging and only have delayed or late venous, it looks almost like an infiltrating tumor. And I've seen a number of these called TCCs because there's low density in the region of the renal pelvis, but that's simply because the blood's not there because it washed out very quickly. So you need to be very careful. It's one of the reasons I like arterial phase imaging so much. There's so much less you can possibly miss. We also talk about aneurysms. Now, aneurysms can be small or can be large. Over 2 centimeters, they typically need to be embolized. Sometimes they're resected. If they're too large, they may have calcifications or not. Typically, they will opacify in great part. Usually, they're not totally occluded. Usually, 2 centimeters is the magic number when patients will have intervention in renal artery aneurysms. When you have a renal artery aneurysm, you want to look for multiple aneurysms. You want to look for the contralateral kidney. You also want to look at the patient's splenic artery, hepatic artery, mesenteric vessels. When you see one aneurysm, it's common to have another aneurysm somewhere. So you want to look at things very, very carefully. So that's really when you think about it. Those are the main things: anatomy, stenosis, beating, fibromuscular dysplasia, renal AV malformations, renal artery aneurysms, and then renal artery fistulae, AV fistulae, which most commonly is due to trauma, often due to a biopsy. And in those cases, not only do you see this cluster of vessels, but this early draining into the patient's renal vein, and you could follow the contrast going up into the renal vein. So, and then it goes into the IVC, of course. So that's when you know very, very flash filling. And then finally, I mentioned to you that we also think about the renal artery in tumors. Again, tumor staging, tumor invasion, differentiating clear cell from papillary, from chromophobe, from angiomyolipoma. So again, information that we need to have. Now, that becomes very important across the spectrum of findings. And we submit these images to the referring clinicians, and they use them in their practice. Now, that becomes very important. So let me see. If you have questions, maybe it's a good time to ask. Now, first of all, let me see who's here. Lydiana is saying hi from California. Hey, Lydiana. Lydiana's in Southern California. Well, not really Southern California. That means you're in LA. She's more in the Bay Area, sort of. And then Saf, who's from Yemen. I hope everything is getting a little bit quieter in Yemen. So quite a spread of people in terms of just the sheer distance of, I guess, 7,000 miles, though I'm probably going to be off a couple thousand. But if you have questions, it's a good time to ask. Now, in terms of protocols for renal arteries, if I'm looking for renal artery stenosis where my main concern is the renal artery and little else, then I can go with 70 or 80 cc's of contrast. We like to inject 5 cc's a second. And again, as I mentioned, renal arteries alone, you could do arterial phase, but if you want to look for perfusion changes, getting a venous phase at about 90 seconds would be a good idea. In terms of contrast volumes, I mentioned we do FMD, but often we're requested to do diaphragm to pelvis. And so the scan timing is pretty easy. You'll typically start at about 30 seconds, and that'll work out very well. But the thing to remember is if you're scanning larger areas, you might go with higher volumes, 100 to 110, very long, very large patient, maybe 120 cc's. Again, all the protocols are sticking with 5 cc a second injection. So the key thing, of course, is having enough contrast that you're not looking at a fuzzy vessel and either coming up with disease that's not there or missing disease that is there. And both those errors are not uncommon to occur. So that's important. One thing, again, not to change the subject, about Facebook Live, one of the impressive things is with education, this is pre and post-COVID, if we ever get to the post-COVID era, or during COVID, it's important to recognize how things like Facebook Live communicate. So I'm sitting in Baltimore in my kitchen. You can hear noise. It is raining cats and dogs out in Baltimore today. But now Musabar from Kashmir and Hanuk from India both say hi. So it's amazing the breadth. It also makes the point that people want information, whether you're in Kashmir or you're in India or you're in Yemen or you're in California. Everyone's looking for the same story. Everyone is looking for a way is, how can I learn things better, that I can take care of my patients better, that I could do things better? I think that's a commonality wherever we are, whether you're on 16 slice or 640 slice CT. Whatever it is, you are dedicated to the quality of care. And we do commend everybody, particularly in this COVID time. We were making the point that in the COVID time, a lot of people are contracting and staying in. Radiology is the front line. Our frontline workers, the most important people in radiology, are the technologists. There's no technologist, maybe some administrator perhaps. There's no technologist who's working from home. You cannot be scanning from home. You're doing CT, MR, ultrasound, fluoro, plain films, nukes, PETs, angios, you name it, whatever you're doing, you're in there and in person, and you're touching the patient and standing near the patient. You are taking the highest of risks, and I think we salute all of our technologists who've worked so hard and continue to work hard. And unfortunately, this epidemic may be pushing its second phase to us. Will continue to work hard. So I think it's very important to recognize those people And those people are our friends, right? So I've worked closely with them for my whole career. But your quality of CT, I've always said, the reason we do a really good job at Hopkins from a clinical perspective and from a publishing perspective, and why we can do something like CTisus, is because we have really good technologists who help us get really good studies and the best studies possible for the patient. And so we're then able to teach and share information with you, which is very important to us. Now we have Vieko, and I'm sorry, I always pronounce names wrong, from Yugoslavia. So it's amazing just the ability for me to sit here in my kitchen in world famous Owings Mills, Maryland. No one has ever heard of Owings Mill. It's a suburb of Baltimore. It's a little bit famous on PBS way back when. Louis Rukeyser, who did the first financial show and did it for maybe 20 years, would do it from Owings Mills, Maryland. The studio was in a little building, and you could sort of see the building still. It's still being used, but it was a little building the size of this room, very small, and it was just corn around it, corn and grass, a lot of grass. But now, of course, that area is totally built up, and it's kind of a little bit of an eyesore. Every once in a while, the neighbors wanted to close down or something because it's some towers and it's in the middle of a residential neighborhood. But the answer is the residential neighborhood came after them. And so when you bought in knowing they were going to be there. So it's not really a problem. So I've kind of run out of time, I think. But if anyone has any questions, someone asked here, on the topic of COVID, this is from Ayuk, what is the spectrum pathology you've encountered regarding the urinary system, kidneys down to bladder? I think we have seen more cases of cystitis and bladder wall thickening. We have seen cases of pyelonephritis. We've seen cases of infarcts. I think with COVID, a lot of vasculopathies occur. So splenic infarcts, liver abscess, renal infarcts are all things we are seeing. So that becomes very important. I think that's the spectrum. It's mainly infarcts. We see vessel stenosis, particularly in the iliac vessels. And those are the main things. We've seen a lot of cases of GI bleeding, bleeding from small vessels, sometimes spontaneously, most of the time patients who had surgery, but just an increased incidence of really impressive bleeds, which we never really saw. And it doesn't look like the surgery is sloppy. It's really good surgery, but just patients having more complications. And I think that's a COVID-related thing. So COVID has its challenges. I think hopefully we'll be back in a week when we speak. I don't think it's going to happen. Maybe it'll take 2 weeks, but Pfizer is going to announce their results from their vaccine trial. I think that's a very important trial. Pfizer's a great company, and they work with a company in Germany, and they have a lot riding on this vaccine, but more important, we have a lot riding on that vaccine. We want to see our grandchildren, our children, and we want to travel. We need a cure, and we need it now. So Pfizer is going to be the first one reporting. So I think if they can report something good, like over 70% success, I think we're going to all be very happy, and it'll be the first step of many that is necessary to bring us down from this stage we're in. So I think that becomes very exciting. I think, this whole topic of COVID, at least there's another question here. In Yemen, nephrolithiasis is common in COVID patients. That's interesting. A question from Mushabar about oral contrast. I think we spoke about that about 2 weeks ago, again, making the point that oral contrast, when you don't have IV contrast, oral contrast is great. For certain oncology patients, a really good article by Perry Pickard, June AJR, which explains why they missed a lot of things using just IV, and then positive is very good. Again, it's the balance of positive and neutral depending on the application, but for many things, positive is really good. But that lecture, speaking about positive contrast, should be coming out on CTisus in a couple of weeks, so hopefully that'll help you there. So I've kind of run out of time. I want to thank everybody for their attention and their knowledge and sharing with us and asking questions. And we'll keep answering them. And I'll say hi and bye to John from Virag CT. That's our oncology center, outpatient office at Hopkins. So with that, have a great day. Bye.